Good evening, everyone. We are going to commence the lecture for this week, and we'll be discussing peptic ulcer disease. As we mentioned earlier, it's an important disease of medical and surgical importance. However, the improvement of drugs, especially antibiotics for the treatment of Helicobacter pylori, and introduction of newer NSAIDs have significantly reduced the need for surgery for patients with peptic ulcer disease. However, patients who develop complications like intractability, massive upper GI bleeding, perforation, gastric outlet obstruction will still require surgery or suspected malignancy or features of malignancy. They will require surgery. So in this lecture, we will aim at dividing the topic into badges or various segments so that, as usual, we can discuss extensively on this topic. So today, we are going to discuss introduction and epidemiology of peptic ulcer disease. We'll talk on the anatomy, relevant anatomy as regards to peptic ulcer disease and physiology. So, peptic ulcer is an erosion of the lining of the stomach or duodenum caused by the action of gastric acid and pepsin. This imbalance resulting from excessive acid secretion or excessive peptic activity that lead to erosion of the gastric mucosa or the duodenal mucosa will lead to peptic ulcer disease. You should all know that peptic ulcer disease occur in areas that are accessible to acid and pepsin. And these areas include the lower end of the esophagus, the stomach, duodenum. The duodenum, when there is an anastomosis to the stomach, that is following jejunostomy. The jejunum will now have access to this acid secretion and pepsin. Meckel's diverticulum with an ectopic gastric tissue, because the ectopic gastric tissue will produce acid and pepsin. So these are the parts of the bowel that are prone to development of peptic ulcer disease. However, we should note that peptic ulcer disease is common in the first part of the duodenum, and we are going to see the reason shortly, and the stomach, usually in the lesser curvature of the stomach. Is commoner in the lesser curvature as compared to the greater curvature of the stomach. Now, you should know that peptic ulcer disease results when gastric acid and peptic activity overwhelms the defense of the gastroduodenal mucosa. As we mentioned earlier, when there is an imbalance between the mucosal defensive mechanism and the acid peptic activity, this imbalance leads to erosion of the mucosal protective barrier. And this erosion can erode deep to involve the submucosa and even deeper layer. And it might even lead toward perforation of the part of the bowel that is involved. We should know that majority of patients with peptic ulcer disease, there is colonization of the pyloric antrum by Helicobacter pylori. Helicobacter pylori, this is a bacteria that is the most important etiological agent in the development of peptic ulcer disease. It is the most important etiological agent in the development of peptic ulcer disease. Why is that so? Because majority of the patients with peptic ulcer disease are infected with this bacteria. Now we should know that H. pylori is present in about 50% of the world's population. Hence, its infection is the most common cause of peptic ulcer disease. Non-steroidal anti-inflammatory drugs also cause significant damage to the lining of the stomach and the duodenum. Now, regarding the prevalence of PUD, it varies widely between countries, but it's estimated that about 10% of people will develop peptic ulcer at some point in their lifetime. And the estimated prevalence is 10 to 15% in developed countries and 20% in developing countries. You see, it is commoner. It is commoner in the developing countries because Helicobacter pylori is transmitted orally, and it could be a via fecal-oral transmission. So the incidence, prevalence tends to be higher in developing countries as compared to, even though there is no much significant difference, it's 10 to 15%, while in the developing countries is 20%. The incidence of PUD has decreased over the past few decades due to widespread of antibiotics to treat Helicobacter pylori infection, as well as development of newer and safer non-steroidal anti-inflammatory drugs. Now, you should know that peptic ulcer disease still remains a significant cause of morbidity and mortality, particularly in older population. Okay? Now, most of the complications you will see are commoner in older than the younger individuals. And they are more associated with mortality because of presence of concomitant comorbidities these elderly people may have. So the outcomes tend to be more severe when it affects older people as compared to the younger population. Now, the relevant anatomy of the stomach with respect to peptic ulcer disease. The stomach is a J-shaped hollow viscous that is located in the upper abdomen. It is made up of the cardia, the fundus, the body, the antrum, okay, and the pylorus. It has two surfaces, the anterior surface and the posterior surface. The posterior surface is lying on the stomach bed. There are some structures, the left adrenal, the left kidney, the pancreas, the transverse colon. Why is it important? Because if you have a perforating gastric ulcer, it might perforate to involve the structures on the bed, like the pancreas commonly. It has the curvatures, the greater curvature and the lesser curvature. The layers of the stomach is a muscular structure. It has layers of muscle, the longitudinal, the circular, and the oblique layers of muscle. The mucosa of the stomach is thrown into folds that are called rugae, okay? Rugae of mucosa. These rugaes are more marked in the greater curvature as compared to the lesser curvature. And of course, we know the stomach is an organ that stores food for about 3 to 4 hours, where it converts solid to semi-solid, and it mixes with the secretions of the stomach to form chyle, and it releases these contents into the duodenum gradually. Now, the blood supply of the stomach. The stomach is supplied by branches from the celiac trunk. The celiac trunk, this is the celiac trunk, is a branch, an anterior branch of the abdominal aorta. This celiac trunk has 3 branches. It has the splenic artery. This is the splenic artery. It has the hepatic artery, as well as the left gastric artery. Okay. Now, you can see the left gastric artery here supplies the lesser curvature of the stomach. Left gastric artery. The splenic artery gives a branch that is called the left gastroepiploic artery. It gives the left gastroepiploic artery, supplying along the greater curvature of the stomach. The splenic artery also gives short gastric arteries that supplies the fundus of the stomach. Okay, so we have seen 2 branches supplying the stomach from the celiac trunk. The left gastric artery, which is one of the branches of the celiac trunk, supplying the lesser curvature. The splenic artery, which goes behind the stomach, it runs on the posterior surface of the stomach, forming part of the bed. It gives off the left gastroepiploic artery, as well as short gastric arteries that supplies the fundus. The hepatic artery. The hepatic artery divides into the hepatic artery proper. This is the hepatic artery proper, and the gastroduodenal artery. The hepatic artery gives hepatic artery proper and the gastroduodenal artery. This is the hepatic artery proper. and this is the gastroduodenal artery. The gastroduodenal artery gives off the right gastroepiploic. It gives off the right gastroepiploic along the greater curvature, the anastomosis with the left gastroepiploic. The hepatic artery, I said it divides into the hepatic artery proper and the gastroduodenal artery. This is the gastroduodenal artery. The gastroduodenal artery gives the right gastroepiploic artery, the anastomosis, with the left gastroepiploic artery along the greater curvature, and it continues as the superior pancreatico-duodenal artery. It continues as the superior pancreatico-duodenal artery that divides into anterior and posterior branch. Now, the inferior pancreatico-duodenal artery comes from the superior mesenteric artery to anastomose with this. So what you should know, all the supply of the stomach comes from the branches of the celiac trunk. Now, the hepatic artery proper gives off the right gastric artery. Don't forget, we said the left gastric artery arises directly from the celiac trunk. The left gastric artery arises from the celiac trunk, while the right arises from the hepatic artery proper. The reason I'm emphasizing this is because of MCQs. It is very important you understand the blood supply of the stomach. It's very important, okay? The celiac trunk has 3 branches, okay? The left gastric, okay? The splenic that goes to the spleen, this splenic, as well as the hepatic artery. These are the 3 branches. The splenic gives off the left gastroepiploic arteries and short gastric artery supplying the fundus. Then the hepatic artery gives off the hepatic artery proper that goes to the liver to divide into right and left hepatic artery. Then the gastroduodenal artery. This gastroduodenal artery gives off the right gastroepiploic artery and continues as superior pancreatico-duodenal artery. The hepatic artery proper gives off the right gastric artery. So the stomach is richly vascularized from branches of several anastomoses coming from the celiac trunk. Now, there is abundance vascular plexus in the submucosa, except along the lesser curvature and the corresponding part of the first and second part of the duodenum, relatively poorly vascularized. Now, what you need to understand on the relevant anatomy, why these parts of the stomach and the duodenum is prone to peptic ulceration is because of the precarious nature of this region. What are we talking about? Aside these branches that highly vascularize the stomach, there is a vascular plexus in the submucosa of the stomach. And this vascular plexus is precarious in some certain areas. What areas? The lesser curvature and the first and second part of the duodenum. In the submucosal area, this segment generally, the plexus is precarious in the first and second parts of the duodenum, making this part prone to ulceration than other parts of the stomach. So that is what we are talking about here. So some individuals along this precarious region, there are areas of mucosal patches supplied by end arteries arising from outside the stomach wall and not communicating with the submucosal plexus. It's important you understand that even along this part that has precarious vascular plexus from the blood vessels of the stomach, there are some areas containing patches that are even devoid of this plexus completely. Rather, they are having end arteries from outside the stomach. And when you see end arteries, they are terminally blind, not anastomosing with even the adjacent vessels. So in such that any cause of impairment of supply will lead to ischemia and necrosis. So this region also have patches of end artery supply that are not communicating with the submucosal plexus. So you can see all these factors make this part more prone to ulceration. In the duodenum, such patches are in the first 1.5 centimeters. That's why duodenal ulcers are commoner in the first part of the duodenum, okay? And in due course, we'll see most of the ulcers in this first part of the duodenum could either be anterior, posterior, or kissing ulcers. And the anterior ones are the ones that likely perforate. And the posterior ones are the ones that likely bleed when they erode into the gastroduodenal arteries. These are important factors for localization of duodenal ulcer as well as gastric ulcers along the lesser curvature. Now, the innervation of the stomach with respect to peptic ulcer disease. The vagus nerve is the nerve supply of the stomach that is having there are two vagus supplying it. There are two vagus nerves entering into the abdomen via the esophageal hiatus, the anterior and the posterior vagus nerve. Okay, the anterior lies, okay, anteriorly to the stomach at the esophageal hiatus, while the posterior enters via the posterior part of the cardia. And you should know the left vagus is the anterior and the right vagus is the posterior. So you use this mnemonic to recall LAP. Left vagus is anterior and right vagus is posterior. The left is anterior and the right is posterior, entering through the esophageal hiatus. Now you should know it gives the parasympathetic supply to the stomach. And this parasympathetic supply is what? Secretomotor. It stimulates acid secretion as well as digestive enzyme secretion and the contractility of the stomach. The anterior vagus supplies the upper part of the stomach and the lesser curvature. Its terminal part is called the nerve of Letaget. It supplies the antrum. It stimulates acid secretion and motility. The posterior part supplies the greater curvature. It stimulates contraction and release of digestive enzymes. Also gives celiac branch, which distributes to the intestine. Now you should know the celiac branch for other parts of the intestine comes from the posterior vagus. Now it is important you understand this nerve supply of the stomach, because when we are discussing the treatment, it has bearing with this anatomy. You should know okay, if this is the anterior vagus, okay, it enters the abdomen through the esophageal hiatus. You have the anterior vagus and let's say the posterior vagus. Now, just about 2 centimeters from the margin, it gives branches that supplies the stomach. And the terminal branch is called the nerve of Letaget. And this nerve of Letaget is the one that supplies the pyloric antrum. And it is responsible for motor and secretory function of the pyloric antrum. Okay, don't forget the nerve of Letaget is the terminal branch of the anterior vagus. The posterior also supplies the stomach along the greater curvature, and it gives the celiac branch to the celiac plexus. From the celiac plexus, other branches that supplies the intestine arise. Now, during treatment, surgical treatment of peptic ulcer disease, you are going to do a form of treatment called vagotomy that is going to devoid the stomach of acid secretion and peptic secretion, okay? Because of the excessive imbalance is what causes the acid. There's what is called criminal nerve of Grassi. Criminal nerve of Grassi. It's important you know this. a twig just above the esophageal hiatus will arise from the vagus, okay, before it starts branching. A twig above the esophageal hiatus will arise to supply the stomach. And even after vagotomy, patient will present with recurrence or persistent symptoms of peptic ulcer disease. So during vagotomy, you have to look for this twig and denervate it. So you should be conscious of that. So you should know the vagus nerve is the parasympathetic supply, which is secretomotor, that has the anterior and the posterior vagus nerve. Now, the sympathetic supply to the stomach. The sympathetic is thoracolumbar from T5 to T9, then L1. What is the role of the sympathetic supply to the stomach? They regulate the stomach blood supply and the muscular tone of the stomach, okay? You know sympathetic flow regulate vasoconstriction, okay? And when there's sympathetic outflow, there's vasoconstriction. When there's inhibition of sympathetic outflow, there's vasodilatation. So it regulates the blood flow to the stomach, as well as motility and secretions of the stomach also. And they carry afferent pain fibers. The pain fibers are carried along the sympathetic nerves. Now, the histology of the gastric mucosa. Now, all these we are discussing, the anatomy, physiology, forms the basis for understanding the pathophysiology and the treatment of peptic ulcer disease. So it's important you have a good foundation on these bases so that you will understand the treatment when we discuss. The gastric mucosa is thrown into folds called rugae, which is more marked along the greater curvature. The epithelium is formed by alkali mucous secreting cells, studded with minute opening, the gastric pits, through which gastric secretions are poured out. Now, you should know that this stomach is made up of 3 glandular zones. There are some glandular zones in the cardiac region, in the ocentric region, and the pyloric region. Those glands that are located predominantly in the cardiac region contain mainly mucus secreting cells and few parietal cells. The ocentric or parietal region is the fundus. They are located, these glands are located in the fundus and the body, and they contain predominantly parietal cells, which secrete hydrochloric acid and intrinsic factors. You should know the parietal cells secrete HCl and intrinsic factors. Then the glands in the pyloric region contain alkali producing cells and the G cells that produce gastrin. Gastrin, okay, is a hormone that stimulates the parietal cells to produce acid. We are going to see the physiology shortly. Now, what are the types of cells? The various types of cells that are located in the mucosa of the stomach. The surface epithelial cells. The surface epithelial cells produce mucus to form protective barrier against acids. The mucous neck cells produce mucus protective against acid as well. The parietal cells, as we talked about, produce HCl and intrinsic factors, which the intrinsic factor is required for vitamin B absorption. So you should know that the parietal cells are the cells responsible for the acidic medium of the stomach by producing HCl. We'll see how this happens. The chief cells secrete pepsinogen, which is a precursor of the pepsin for digestion of protein. And this precursor pepsinogen requires an acidic medium to be converted into pepsin to exert its digestive function. The G cells secretes gastrin, a hormone that stimulates secretion of HCl and pepsinogen. The D cells secrete somatostatin, which inhibits secretion of gastrin and pepsinogen. So you should know that the somatostatin inhibits acid production. It inhibits pepsin production by inhibiting gastrin. That's why you use octreotide, a somatostatin analog, to block production of gastric, pancreatic, and biliary secretions. Then the enterochromaffin-like cells are located in the body and fundus of the stomach. They secrete histamine, which stimulates the secretion of HCl. Now we are going to talk about the physiology as with respect to peptic ulcer disease. We should all know that the parietal cells are stimulated to secrete hydrochloric acid. Okay? The acid activates pepsinogen to pepsin. Now, what are the stimulus that causes the production of acids by parietal cell? These stimulus include the acetylcholine via the vagus stimulation, the gastrin via the G cell release, and the histamine from the enterochromaffin-like cells. These are the stimulus. When they are stimulated, okay, how do they produce acid? They require an enzyme, and this enzyme is called hydrogen potassium ATPase. It is called proton pump. It is the parietal cell proton pump. And what does it do? It catalyzes the exchange of extracellular potassium and intracellular hydrogen. It is against concentration gradient. That's why it requires ATP. Okay? Because it is moving ions against concentration gradient. Now, chloride accompanies the hydrogen ion when secreted into the lumen to form the hydrochloric acid. You should know that the proton pump inhibitors we use in the treatment of peptic ulcer disease, they irreversibly interfere the function of the proton pump, which is the hydrogen potassium ATPase molecule. Okay? And you should know that this proton pump we give, they only act when these proton pumps are activated. They only act on the hydrogen potassium ATPase when they are activated. And how are they activated? It is when the stimulation of acid stimulation, okay, of acid secretion that they are activated, like during feeding or in an empty stomach. That's why it's good when you are taking proton pump inhibitor, you should take it with meals so that the ATPase will be activated so that it can now block these receptors. okay, or you should take it before meals. And when you continuously take the PPI over the prescribed duration, it keeps on irreversibly blocking all the receptors in the molecules. If you stop taking it, what happens? There's production of newer molecules, and the patient will now have recurrence of the symptoms. And you should know that the human stomach contains approximately 1 billion parietal cells, and the total acid output is proportional to the parietal cell mass. Then the gastrin, how else, aside via stimulation of the proton pump directly, we have gastrin binds to type B cholecystokinin, that is the CCK2 receptors on the enterochromaffin-like cells, and stimulate histamine release. When the gastrin stimulate the ECL cells to release histamine, what does the histamine do? The histamine now binds to the H2 receptors on the parietal cells. So histamine is also required to bind to parietal cells, leading to what? A sequence that activates proton pump to produce acid. Acetylcholine also binds to muscarinic receptors, M3, on the parietal cell to activate the proton pump to release HCl. You should know that the most potent physiologic stimulus for pepsinogen secretion is food. Feeding. Okay? And the pepsinogen is now activated by the acidic environment. So we have successfully discussed the epidemiology of peptic ulcer disease, what a peptic ulcer disease is. We also discussed the common site it affects, the epidemiology of peptic ulcer disease, the anatomy, and the physiology. So we are going to stop here for today. Then probably tomorrow we'll continue with the classification and pathophysiology as well as clinical presentation. And in the third lecture, we will now talk on the detailed management of peptic ulcer disease. So we are going to stop here, then I will entertain questions. Okay, if you have any questions, you can, okay, unmute yourself, then you ask. Thank you very much. So if you have any question, you can unmute yourself and ask, okay? Any question, please? Do we have any question? If you have any question, you can unmute yourself and ask. Okay, it appears because it's the introductory part. Do you have any questions? Okay. Okay, it appears we don't have. So in the absence of any question, we are going to stop the lecture here for today. And probably tomorrow, we are going to continue. Thank you very much. Thank you, everybody, for participating. I'm going to...
Thank you, sir.
Yeah.